فينس ديزيز هذه المحاضرة أخذناها العام الماضي. طبعا هي عندنا mainly we're talking here about the DVT and venous insufficiency syndrome and varicose vein, which is part of venous insufficiency syndrome. So again, difference between the artery and vein. The vein is more thin and has unidirectional valve. Venous disorder, as I mentioned, thrombosis, either superficial thrombosis يصير عندنا thrombophlebitis or deep thrombosis يصير عندنا DVT. Chronic venous insufficiency and varicose vein, as I mentioned, if you remember last year, they are the same, but we call it chronic venous insufficiency if the insufficiency affecting deep veins, deep system only. If the insufficiency affects only the superficial system, we call it varicose veins. طبعا this is anatomy. Superficial veins, deep vein, perforated. Superficial veins and the long saphenous vein in the leg and short saphenous, they are the most common or the main superficial veins. What are the mechanisms of venous return? If you remember, there are 4 mechanisms. Unidirectional valves can help in the venous return because the blood will go in one direction, will not come back. Leg muscle pump is very important while walking. Foot sole and ankle pump is very important also while walking, and respiratory pump. So valves in the veins, very simple. So it's anatomically unidirectional. So when the blood goes in one direction, the valves will prevent the blood coming back against the gravity. Calf muscle pump, it's usually pump the vein, the muscle compress the veins, especially the deep veins, and will help the venous return. Also the foot and ankle pump as well, it will help and contribute to more than 50% of blood leaving the calf. Respiratory pump, usually with the change in the pressure in the thorax, it will induce in the by breathing and changing the pressure in the thoracic cavity, most of the blood will be sucked upwards towards the heart. If you remember, so if the patient's anyone who's lying down, usually the venous pressure is about 10 millimeter mercury. With standing, it goes up to 90 millimeter mercury. With walking, this pressure, the 90 millimeter mercury, will go down to 25 millimeter mercury because of what? Because of the things that I mentioned just now, اللي هي muscle pump, ankle and foot pump, and breathing. Okay. If the pressure with walking is higher than 25 millimeter mercury, means that there is a problem. There is increase in the venous pressure. اللي هو ambulatory venous pressure. So ambulatory venous pressure, usually, as I mentioned, 25 millimeter mercury. If it's more than that, means there is a problem in one of the mechanisms. Chronic venous insufficiency, again, هي نفس principle, either superficial or deep system. But if I just mention chronic venous insufficiency, usually I mean deep system. So valvular incompetence mainly causing this problem. هيكون في continued reflux and increase in the ambulatory venous pressure. This venous insufficiency might lead to venous ulcer زي ما حنشرحها في clinical session. ليش حتصير؟ طبعا you don't have to know the details, but it's mainly secondary to stasis. Increasing the venous pressure, stasis might cause extravasation of inflammatory cells outside the veins and inflammatory process of the subcutaneous tissue and skin and lead up to ulcers. So the venous insufficiency can affect either superficial alone or deep alone or perforators. So we can classify it as this, and also we can classify it as the cause. What is the cause of this insufficiency? So either primary or secondary. So usually primary, there is no pathology because this problem is just only related to weakness of the valve or the venous wall. It's usually genetics or familial, as in the varicose veins. Whereas secondary means that there was a problem, there was a pathology like DVT. So لما يصير في DVT, most of the DVT, the chronic thrombus will destroy the valve, the deep venous valve, and then يكون حتى لما تروح الثرومبس, if the DVT goes away, the valve will be destroyed, and then يكون عندي reflux. عشان كذا احنا نسمي اللي صار عندهم DVT and then they get venous insufficiency, we call them post-venous post-phlebitis syndrome. Clinical evaluation, طبعا we have asymptomatic, we have all patients came in with only cosmetic problem with dilated veins like varicose veins, and some of them has symptoms like pain and swelling, especially with standing. Some of them will end up with skin changes, ulcer, and as we see here, there is a venous ulcer. طبعا venous ulcer تصير في medial part, medial aspect of the leg, especially lower part. Here, there is some skin changes. There are just the dilated veins and varicosities. There are ongoing ulcers, as we see here. Clinical test, you don't have to remember all of that. Okay, no need. طبعا حنشرح لكم التست في الكلينيكال sessions إن شاء الله. If the venous insufficiency is affecting only the superficial system, we call it varicose vein, which is the most common vascular disease. مو حتى venous disease, most common vascular disease. اللي منكم يصير vascular surgeon later, the most patients you will see in your practice are varicose veins. It's very common. It goes up to 50% of the female and about 25% or 30% of the, 50% in the female and 45% in the male, especially لما يكون عندي only small varicosities. It's very, very, very common. في definitions لازم تعرفوها عشان لما تعمل examination which is mainly inspection only زي ما حنشرح بكره إن شاء الله عشان تعرف تفرق. So telangiectasia, it's usually very, very small dilated veins less than 1 millimeter in diameter. Reticular veins لما تكون between 1 and 3 millimeters. And then I say varicose vein if it's more than 3 millimeter. شايفين on the left side of the screen there's telangiectasia and reticular veins. Here on the right side there is dilated veins اللي نسميهم varicose veins. About risk factors varicose veins, there are risk factors like female gender, advanced age, Caucasian race, family history. These are the risk factor. On the right side of the screen, those are not a risk factor but accelerators only. الناس كثير منها ما تفرق بين الريسك فاكتورز وهذول فيقول لك risk factors obesity pregnancy. No, those are accelerator. Pregnancy will not cause varicose veins, but pregnancy will accelerate it, will make it I mean quicker. That's it. Obesity as well. Obesity itself, it will not cause varicose vein. But if the patient has risk factors of varicose veins and obesity, it will show faster. That's it. Professions like long standing, like teachers, for example, are most affected as well. Physical examination is very, very important, as we will mention tomorrow. Usually needs to be with standing, not lying down. There are some classifications that can help with examination, or a CAAP classification. C stands from clinical, E from etiological, A anatomy, and B pathophysiology. طبعا the most important one is clinical. C اللي هي clinical, C0 no sign or symptoms, C1 only telangiectasia and spider vein, C2 varicose veins, C3 varicose vein with edema. Okay, زي ما احنا شايفين في الصورة هنا. C4 يكون عندنا skin changes. Okay, C5 في healed ulcer, skin changes sorry هنا C5 يكون في healed ulcer ما هي واضحة, and C6 active ongoing ulcer. So C classification can help in the clinical exam. E from etiology, either congenital or primary or secondary, post-thrombotic, post-traumatic or other. E from anatomy, either superficial or deep or perforators. P from pathophysiology, either reflux or obstruction or reflux and obstruction. So an investigation, the most important investigation, and the one that we rely on is Dublix, venous Dublix. With the venous Dublix, we can see the anatomy, we can see if there is a thrombus, if there is obstruction, and we can detect the reflux. إيش هو reflux? So I put the tracer inside the vein, and then I squeeze the calf muscle. So the reflux should be, normal reflux should be less than 0.5 second. So لما أضغط على الكالف muscle يصير سريع. So الفالف يتسكر. Pathological reflux if it's more than 0.5 seconds. So لما أضغط على الكالف muscle هيكون أبطأ. So this is pathological reflux. From this, I diagnose if there is a reflux in the vein or not. طبعا we can do something more invasive like venogram, but nobody does venogram now to diagnose DVT or diagnose varicose veins. طبعا treatment option for varicosities or varicose veins اللي هي venous insufficiency in the superficial system. So conservative management, we start with always with compression, stocking, and then we go for sclerotherapy, especially for cosmetics, and then we go for intervention. So compression therapy with either stocking, اللي هي compression stocking, there are a lot of classes. Usually we use class 2 for varicose vein. Class 3 هذه we use for lymphedema. Class 1, this is just for DVT prophylaxis. So for varicose veins, usually class 2 اللي هي between تقريبا 15 to 25 millimeter mercury. Pharmacological حطوا عليها X. This slide I don't want it. Then we go for sclerotherapy. There are many sclerosants like polydecanol or hypertonic saline. We just like, usually we use it cosmetics, especially if the patient has no reflux in the great saphenous vein or short saphenous vein, but has dilated small veins and they do want it cosmetically. So we can inject them in the clinic with some of the sclerosant to reduce to make the appearance better. Also, we can use foam sclerotherapy from the same material, but make it form for bigger veins. Then we go for the surgical management and intervention. طبعا surgical management is not, nobody does it. Maybe some in the peripheries will do it still. So if you have a reflux in the great saphenous veins, this is the main problem. So you have to take that vein out. So you ligate the vein at the saphenofemoral junction and we strip the vein completely. But we don't do it, we do something else interventional, either endovenous laser therapy or endovenous ablation or even a glue injection in that vein. So instead of taking that vein out completely, so same thing, we just close the vein while inside the body. So it's minimal invasive under local anesthesia. We puncture the vein, we go up with the wire, with the catheter, has a laser, and with this laser or with radio frequency, it makes burning of that vein and thrombosis, fibrosis and thrombosis. Then I go to the deep to the DVT. So DVT is very, very common, and unfortunately the mortality and morbidity after the DVT is high. We have to be careful, especially for the hospitalized patient. So 80 to 90% of the PE usually originate from the lower limb DVT. We remember Virchow triad زي ما قلنا من شوية سواء في الارtery or veins. So stasis, hypercoagulable status, endothelial injury can cause thrombosis. Status like what? I'm talking about DVT now, like advanced age, obesity, prolonged bed rest, immobilization, limb paralysis, extended limb travel. That's why any hospitalized patient, and hospitalized patients usually they stay in the bed, that we have to give prophylactic dose of anticoagulation to prevent DVT. And DVT in the hospitalized patients is very high. Hypercoagulable status like malignancies, surgery, trauma, inherited disorder, or acquired disorder of coagulation. Endothelial injury like what? Surgery, trauma, iatrogenic injury, as I mentioned earlier. So DVT either asymptomatic or symptomatic. لما يكون عندنا symptomatic patient with acute DVT, usually they present with just pain and edema, sometimes phlegmasia of the leg. I mean change in the color. طبعا يكون عندهم pain also when you dorsiflex their foot, they have pain. Complication of the DVT, the immediate complication which you do want to happen, which is PE طبعا, up to 30%. Long-term complication, something called post-thrombotic syndrome, اللي من شوية I mentioned. If the patient has reflux secondary to the DVT, we call it post-thrombotic syndrome. يكون عندهم usually pain and swelling while walking and standing. Diagnosis, we can use D-dimer. D-dimer will not diagnose. So negative result will rule out the DVT, but the positive result will not rule it out. Rule it in, I mean. So it's not so specific. So the specific and sensitive one is the Dublix Ultrasound. So it has 96% sensitivity and 100% specificity. It will show dilated vein with non-compressible lumen. Venography as well, it can help if you don't have Dublix. Other tables you don't have to remember exactly, just I need you to remember that for any admitted patient or hospitalized patient, there are a risk of DVT, and in any hospital حيكون فيه protocol or guideline classifying the patient under either low risk, moderate risk, and high risk, and very high risk. بناء على هذه الريسك نعطي الدوز of prophylactic anticoagulation. طبعا if the patient has DVT, you have to treat with what? With anticoagulation, okay? Also, again, you don't have to remember how long and for how long. طبعا عندنا نوعين من anticoagulation. We have unfractionated heparin, we have low molecular weight heparin, and we have oral stuff like warfarin. So you have to anticoagulate the patient. In some patient who has refractory DVT, or those patient has complication of anticoagulation, or complication of anticoagulation, or patient cannot take anticoagulation for contraindication, I mean any other contraindication like bleeding, or patient has another DVT while on anticoagulation, it's preferred to put a vena cava filter, inferior vena cava filter, to prevent PE. واضح? So inferior vena cava filter is usually used as a prophylactic method to prevent PE if the patient has another DVT while on anticoagulation, or complication of anticoagulation, or cannot use anticoagulation for some reason. You put an IVC filter. Phlegmasia لما يكون عندي very severe swelling, TVT end up with very severe swelling. Sometimes it causes phlegmasia, means that ischemia at the level of the skin and the subcutaneous tissue only. So حيكون في confusion. يكلموك يقول لك oh patient maybe has acute limb ischemia. You go, you will find a pulse, but تكون leg pale secondary to the severe swelling only. طبعا treatment same as DVT اللي هي leg elevation, compression, and anticoagulation. Any question?